Okay, we'll start. Yeah. Good afternoon. I'm Dr. Mohamed Mattar. I'm consultant vascular surgery and I'm diabetic foot surgeon. And I am the co-founder of Diabetic Food Center in Egypt. We're speaking English because we have a guest from Germany. Yeah. Hello. How are you? Yeah.
Hello,
Okay.
good evening.
Yeah.
Thank
Good
you.
evening.
I'm fine.
Okay. Thank
Greetings
you.
from the snow.
Okay. Now we'll start our presentation. Dr. Mohamed Ramadan is our senior consultant vascular surgeon. Dr. Mohamed, he is a diabetic foot surgeon and he's a consultant for vascular and endovascular surgery. He's one of our consultants in Diabetic Food Center in Egypt, and he's one of senior consultant in Sahel teaching hospital. Dr. Mohamed is known in Egypt by his work in vascular surgery and in diabetic foot. Also, he is working at endovascular, vascular lab, and so on. Mohamed will present today a unique lectures, and it will be followed next time also with another one for critical limb ischemia. This is our center in Cairo, Diabetic Food Center. All of us is coming from this umbrella. The presentation will be management of chronic limb threatening ischemia. During the presentation, anyone has a question, he can send it as a text in the chat. And Dr. Mohamed will read it and will answer it. We'll make the questions at the end of each lecture. It will be in text one. Okay, Dr. Mohamed will start now. Dr. Mohamed, Mr. Mohamed, give Dr. Mohamed the sharing screen.
Hi, good evening. Can you hear me?
Yes, yes.
Thank you, Dr. Mattar, for giving me this opportunity and having me here today. Good evening, everyone. My name is Mohamed Ramadan, consultant vascular and vascular surgeon. The title I has been given is Management of Chronic Limb Threatening Ischemia in Diabetic Patients. I will stop the video. Well, this is our agenda today. What is the definition of chronic limb threatening ischemia, how to assess it, and I will focus my presentation today about the endovascular intervention for this situation. Well, chronic limb threatening ischemia is a recent term, have been published in the Global Vascular Guidelines a few years ago. It was previously known as critical limb ischemia. This is the term that I have used to use since I started this career. And it represents tissue loss or gangrene, wrist pain. This is Fontaine classification, class 3 and 4 for peripheral arterial disease. And for for the classification, another one that's famous known, it's class 4, 5, and 6. But of course, we know that gangrene or ulcer or even painful feet is not a meaning of ischemia. The patient must have a hemodynamic significant peripheral arterial disease. Now, the problem is we don't have a consensus. What is better to use to have a hemodynamic parameter describing the ischemia of the patient? It's worldwide used, the ankle brachial pressure index. What is ankle brachial pressure index? you obtain the highest pressure in the posterior tibial and the anterior tibial in the affected limb, and you divide it over the highest brachial systolic pressure, and you should get a number. This number is considered normal if it was above 0.9. But as you see here in this picture, I hope you can see. Let me put a pointer. In this picture, we can see that those are the tibial vessels, the posterior tibial and the anterior tibial. They are heavily calcified, and that's why when you put the pressure cuff here, you can't have any pressure that occludes the artery. So the ankle brachial pressure index is almost always in these patients a falsely elevated or high. That gives you a normal ankle brachial pressure index while the patient is still ischemic. So we can also use another option is the toe pressure, that is using another specific cuff to measure the pressure here on the toes. But as we see also, diabetic patients have frequent calcified digital arteries, and also we commonly see the patients with no toes. So the toe pressure is not a successful hemodynamic parameter in our patients. Another option is the transcutaneous oxygen saturation, which is a device with a consumable disposable modules used, and it's actually not successful for screening of all patients. So because of unavailable successful hemodynamic parameter to assess the degree of ischemia of those patients, Dr. Shahd and his colleagues and his team 20 years ago invented the ankle peak systolic velocity, which is simply replacing the assessment of ischemia by using pressures, by using the velocities. And you attune it by having the systolic velocity in the peak systolic velocity in the anterior tibial artery and the posterior tibial artery, and we get the average of both. And according to the number, we can classify the degree of ischemia of the patient. And they found that below 25 centimeters per second, it's severe ischemia. From 25 to 75, it's moderate ischemia. And you can see how wide this range is. And above 75 centimeters per second, the patient is considered whether no ischemia or mild ischemia according to the findings. So if we have multiple degrees of ischemia, when to intervene? So another publication by Dr. Shahd and also his team, they found that the number 35 centimeters per second is a threshold, that below this number, we can predict lung healing. So if the patient is having gangrene or ulcer or even wrist pain, and his ankle peak systolic velocity is below 35 per second, the patient is probably will not improve without a revascularization. And if we look back now, all the classification system used for diabetic foot ulcer or diabetic foot wounds would have a specific prospect. So most of the cases, we classify the wound like the University of Texas classification, the Wagner classification, and sometimes they classify the infection like the ITSA guidelines, the Infectious Disease of America. And we, in our category, we classify the ischemia according to Rutherford and to Fountain classification, but this is not integrated management of the diabetic foot wound. So the last, I say 13 or 14 years, the vascular surgery adopted the Wi-Fi classification, which will combine all the wound, the infection, and the foot ischemia in one classification to determine how to evaluate and how to manage those patients. So the Y classification has the wound with multiple classes and the ischemia, but they are using the ankle brachial index, which is not available, which was not variable, which is not valuable in these patients, and foot ischemia here. So if we diagnose the patient to have a chronic limb-threatening ischemia, and the patient should be revascularized, what options do we have? The first of all is the best medical therapy, which is always used for all the patients, which is glycemic control, blood pressure control, control of all risk factors like smoking cessation, use of antiplatelet therapy, use of lipid-lowering drugs. And the patient revascularization should be used by catheter-based interventions in most of cases, or by open bypass, or by hybrid, using both catheter-based intervention and open bypass. And after reviewing our patients, we saw that we almost use the catheter-based intervention in 95% of our cases. Actually, this is an abstract representing an internal audit of our cases in the Diabetic Food Center. It was accepted as an abstract in Link, one of the most famous international courses, 2019. Also, this is with the strategy used as endovascular first. It's a worldwide famous strategy now. That means you have to try to treat the patient with endovascular as it possible. So endovascular interventions have the most important, the four pillars. I call it the four pillars: the access, the crossing, the treatment, and the completion angiogram. And to start with, the access. The access is meaning that you have to enter the artery to navigate and to treat the diseased segments. The access, in most of cases, is femoral access, and we choose it according to how healthy it is and how far it is from the diseased segment. And as I said, in most of cases, it's a femoral access antegrade that to treat the same limb. Sometimes we use contralateral retrograde access to treat the iliac and aortic disease, not occlusion, or to cross over to treat the contralateral limb. Sometimes we use the brachial access to navigate and to treat aorta, iliac, or even lower limb. And sometimes we use a retrograde popliteal access if the antegrade treatment is not successful. And sometimes we use the pedal retrograde access if both popliteal and antegrade access is not successful. Now, the crossing is the most important step, and it's totally dependent on the technology and some skills of the operator. And for this technology, we depend on the guide wire technology. In most of cases in our team, we depend on the 0.018-inch guide wires, which have different tip loads, which mean the ability of the wire to penetrate the occlusion. And this will be, of course, guided by different shapes of diagnostic catheters. And in many times, the occlusion is very difficult. So we have to use what's called a braided or support catheters. So they are famous like the CXI, the Trailblazer, the Navicross, and the Rubicon catheters. They also have whether 14, 18, or 35 platform. Now the most important step is the treatment. And in most of times, it depends on balloons, just balloons. And the balloons have different shapes, different diameters, 3, 4, 5, 6, sometimes it's 2 millimeters, sometimes it's more in venous interventions. And of course, it has what's called the profile, how small they can be, and this will help the penetration power of the balloon. And so they have what's called the over the wire, which is mostly 4 or 5 French in diameter, or a smaller profile balloons that have more penetration power. It's called monorail or not over the wire balloon. And sometimes we are treating a plaque that is very calcified, so we have to use a balloon with a higher an anti-proliferative drug like they have a specific indication in cases when the patient had renal impairment. Sometimes if the patient have the patency of artery is needed for a long period, if he has a long. Sometimes we need something called the debulking if we want to remove the atheroma from the artery to maintain the post-operative patency. And those are fancy devices used sometimes rotation. It's called Rotarex, or directional, like when it's called turbo. Sometimes we use laser or ultrasound to debulk. Sometimes we use the intravascular lithotripsy, which is shock wave. And sometimes to maintain the long-term patency, we use what's called the radiotherapy. Now, to maintain good results of patent artery, we sometimes use the stents. The stents have specific types, like balloon mounted stents. Is balloon put inside the stent, and we have another type which is very famous and this was used now is the self-expandable stent, which is stent sheathed, and after we remove the sheath, it has a memory and it will take its size that is designed for. And sometimes this stent is also have anti-proliferative drug on it. It's not have a specific indication now. Mostly it's used for claudication patients, not for critical ischemia, as there is no better outcome in using this stent regarding the diabetic foot ulcer. And sometimes the artery we are treating is a very tricky artery, with very flexible artery, like the popliteal artery, or the artery is crossing the joints. So it's better to use a very formal stent that is very resistive for fracture, like the superior stent. Also, the response tools can be used sometimes, like ultrasound, which is not used until it's very rare to be used. Another option is the re-entry device. When we are going to do an intervention, sometimes we get trapped into the subintimal plane, the long occlusions, and we fail to get back for the lumen of the artery. So sometimes this device or sometimes device like it help to get back. Also, anyone is going to have intervention should have these tools on board because they can save the, like this one, this snare, usually used to pick up something lost inside the arterial or venous system. This is the thrombolytic thrombectomy catheter to suck up the thrombus that's formed while doing intervention. Sometimes we have an acute ischemia or acute thrombotic occlusion of the artery, and we need to inject a thrombotic agent like the Actelize. And this is the catheter with multiple fenestrations used to do this procedure. And sometimes we have what's called mechanical thrombectomy, like one is called the angiojet. It's a machine that pushes saline and suck it back to dismantle the thrombus. This is one of the patients that I have encompassed lately. After I finished my intervention, it was venous intervention. I found that a piece of the catheter used torn and implies to be in the right pulmonary artery. So I used this nerve to pick it up. I don't know why it works. So I'm going to present the most maybe beautiful part in this presentation in the cases. This is the case number one. This is a 75 years female. She has type 2 diabetes with ischemic cardiomyopathy. She have a large leg ulcer and toes with non-healing wounds. Was her diplex. She has a long, insignificant disease of the superficial femoral artery with a short popliteal artery occlusion. And the mention here should be mentioned that the popliteal artery, although it was patent, but it was unhealthy. That's why when we try to cross this lesion, it's very, very unlikely to get back for the lumen. Usually we get trapped inside the wall of the artery and we fail to get back here for this lumen. That's why we should have another tick to encompass and to overcrowd this problem. Who is the patient? That was the popliteal occlusion that I have shown in the duplex. And we couldn't cross from the antegrade side. So we have to do a pedal retrograde access. This is the navicular bone and this is the needle. We are trying to engage and to get inside the dorsal artery. And this is how we did it. We succeeded to go upward. And here the wire coming from the dorsal artery till the proximal part of the occlusive popliteal artery. Then we succeeded to cross upward here in the superficial femoral artery. Then we did a stenting. This is the severe stent down to the proximal anterior tibial artery. And this is after we could establish the flow to the dorsal artery. This is the second case. He is a 65-year-old male with diabetes, have non-healing post-toe amputation. The patient had popliteal artery disease, distal SFA disease, popliteal artery disease, had a completely occluded posterior tibial artery, and some proximal tibial artery disease. And this is when we started the procedure. The SFA is completely patent. The distal SFA had a significant lesion here. And this is the diseased popliteal artery. Diseased popliteal artery also. This is the tibial trunk, which almost fades, and the posterior artery is occluded. And this is the foot of the patient. The patient has only dorsalis pedis artery with no plantar artery here. We succeeded to cross all the way down to the plantar artery here that appeared at final. Then we started to treat with the ballooning. And here is the distal flow in the popliteal artery. It was very nice. Now, as we see here, the popliteal artery after ballooning was multiple dissections appeared, and that was risky to leave. So we did go for stenting. This is again the superior stent. And the beautiful of this stent is very confirmable. This is the knee joint flexed 90 degrees almost, and the stent doesn't show any compression. And this is after we finished here. The SFA, here the stent in the popliteal artery with very nice flow. Here. And at last, the foot of the patient, the most beautiful picture. Thank you for your listening. Dr. Mattar.
Yeah, we now can start question and answers. Any question can be anyone want to ask, write the question in the text in the chat. I already asked the question. Anyone who want to ask, he can start to ask.
Yes, I can answer your question, Dr. Mattar. You asked this question: how can you predict success of catheter?
Yeah, because
yes.
Usually patient and family ask you, is it successful? To which extent?
Well, it depends upon multiple variables. Number one is the expertise, the experience of the operator. Number two is the technology available. So when you have a good experience and you have a very good preoperative planning with a very good prepared tools, usually the success rate is almost 90% or more, as we see in our patients. But of course, if we don't have a very good preoperative duplex, it will have a very bad planning, and you will not have a very good stock of tools available, and that's is a predictor of failure.
Is there difference between working based on duplex or working based on CTA?
Well, I kind of have bias for duplex because we tended to assess our patients by duplex for 14 or 15 years now. Actually, the duplex can give you more information than any CT in the world, because you can see the nature of the occlusion, the length of the occlusion, and you can predict if the patient will have a successful intervention or not. This kind of information you can never get from CTA.
Yes. I know the hemodynamic part, you can't get it from CTA.
No,
Okay.
I want
Yeah.
ask
Okay.
me to add something here. You know that CTA depends upon the calcification of the wall. If you are trying to decrease the hazard of calcification appeared in the CTA, you might endanger the flow itself. So sometimes you see the tibials occluded while they are not occluded. So if you see some patients of ours that have all tibials didn't appear in the CTA, you will say there is no flow, there is no runoff, and the patient is condemned and will be for Biruni amputation definitely. But after we do duplex, we can find flow, we can find distal runoff, and that will give the patient some sort of hope.
Okay. Any questions? Okay. Thank you, Dr. Mohamed. I learned from this lecture, and it was it's just a road mapping which tools we can use. And as I work with you, and I know the success rate with our work is above 80%. And we need to monitor more, how to follow up, and so on. Okay. The second presentation with Dr. Beate. She from Global Senior Product Manager, Biosurgical, Advanced Medical Solutions, Surgical Business Unit. Dr. Mohamed will give you the share screen, and you can give us the presentation. You have 10 minutes.
Thank you very much. Good evening, ladies and gentlemen. My name is Beate Ruhl from Advanced Medical Solutions, Resorba, from Germany. And I will present you today our collagen gentamicin device and the use in vascular surgery. If you have questions, please let me know. What is it? Gentacol Resorb is a collagen gentamicin implant, a soft and white collagen sponge derived from horse tendons, so equine tendons, and we incorporate into the collagen gentamicin 2 milligram per square centimeter. So that means that you have in a 10 by 10 or 5 by 20 sponge 200 milligram gentamicin in total, 50 in the 5 by 5 sponge, and 12.5 in the 2.5 by 2.5 sponge. The product is indicated for use to add hemostasis in all kinds of surgery, not only vascular surgery, to promote wound healing, and of course to release over time gentamicin sulfate. The release or the constant release of gentamicin sulfate over a period from around about 3 to 7 days leads to very, very high local gentamicin levels. And you know, in vascular surgery, when the blood supply is really bad or is really low, then it is very difficult to get sufficient antibiotic concentration in the desired area. And with gentamicin, this could help you as well prophylactically for a couple of different vascular indications. How to use Gentacol Resorb? The dosage always depends on the size of the wound and, of course, on the body weight of the patient, because you don't want to poison your patient with gentamicin. For smaller wounds, please use smaller sponges or cut them to size. For bone grafting, I mean, you don't do bone grafting in vascular surgery on a regular basis, but for example, for the Charcot food, if you want to do spongioplasty, then use the ratio 2:1, which means use 2 parts of cancellous bone or synthetic bone or whatever you prefer, and 1 part of the collagen gentamicin sponge. You can cut it in really tiny pieces and mix it with the bone graft. And on the other side, you can just have a look on the body weight of the patient. So that means that you can use for a patient with 50 kilogram up to 3 sponges 10 by 10. But there's a conversion table in the IFU. You can look it up. The collagen is helping to ensure hemostasis also
I'm sorry, I'm sorry to interrupt you, but the presentation, yes? I couldn't see the presentation. It's the only first slide.
Oh. It's always the same slide. It's not moving.
No.
Okay. Then I will share again. Can you see it now?
The first slide, this is the first one.
The first one, okay. And now?
Still the first one.
It's not moving?
No. At least to me.
I'm sorry for that, but
never mind.
I will try again.
Okay.
Can you see the screen?
Yes. It's moving now.
Now it's moving?
Yes.
Okay. Then we will do again.
Okay.
So the collagen will help for hemostasis, also in vascular procedures. You can use it as well for stitching channel, to avoid stitching channel bleeding in vascular prostheses. The collagen provides a guide rail effect, and it helps as well the cells to grow in, so it aids wound healing. The collagen has limited or nearly no immunogenicity. That means that our collagen is highly cleaned. And that means we will remove all the telopeptides, and this will not cause any immunogenicity in your patients. It's only naturally cross-linked, so it contains only natural cross-linked collagen and gentamicin. We do not add any other chemicals. It is, of course, biocompatible. It is highly absorbent. It can absorb large amounts of wound fluids and cell debris, and it is not changing in volume, so it's not swelling. That means you don't have to fear pressure on nerves or vessels. Yeah? And it is as well structurally stable and elastic after application, so in dry and in wet stage. The gentamicin, of course, is an aminoglycoside antibiotic. It is a broad-spectrum antibiotic, which helps you to avoid higher infection rates in vascular.
I'm sorry, Adine, but
yes,
the slide is not moving. It's still on the first slide. It moved and stopped.
I think the problem is that you didn't put it in a presentation mode.
I did.
We can see your next slide.
And it's now moving?
No, we can still see the slides, the side slides.
But
I
put it in presentation mode. I have no idea why it doesn't work.
Yeah, this is now the second for.
I think you have to put this the slide you want to talk about every time.
Move it manually.
I do. I move it manually. Is it moving now?
No.
Sorry.
Now we can see slide number 7.
Oh, now you can see slide number 7. So now you see slide number 5?
No, there is no slide at all.
Yeah. Okay, so technically it will not work. Then we have to do it without a presentation. I'm sorry. Or maybe my colleague Dr. Ahmed can share the presentation because he has it as well.
Okay. Dr. Ahmed, you want to take the share?
I mean, we can try it again. And maybe we try it without presentation mode. Can you see now slide number 5?
Yes.
Yes.
Okay. And when I scroll to slide number 6, is it moving?
Yeah.
Okay. Then we have to do it without presentation mode.
Okay.
I'm sorry for that.
Okay, never mind. Okay.
So the gentamicin is an aminoglycoside, a broad-spectrum antibiotic. It is effective against gram-positive and gram-negative bacteria, and it provides prophylactic antibiotic protection in area where you are not able to get a sufficient antibiotic concentration in because of the bad blood supply. It provides really high local concentrations. That means that it can hit the MIC by around about 150 times on the first day. After 2 to 6 hours, you have such a high concentration that it will hit the MIC by around about 150 times. Then it goes down until day 3, and it will stay above the MIC for around about 7 days. Questions about that? No? Good. So the 2 types of application, so you can use it either dry, but please always ensure that you don't overpack wounds, that you don't pack around vascular implants too hardly. Always pack the wound loosely. Do not compact too much, and the sponges can be folded, rolled, or cut to the desired size. And of course, the topical use in chronic wounds, diabetic foots, for example, or as well in secondary wound healing. You can moisten them with a little bit of warm saline, especially when you have a very dry arterial wound. And if the wound is moist enough, then you don't have to moist it with saline. You can just put it on dry. Replaces when you change the normal dressings. You have to fix it with a dressing because it will not stay over there. So you have to do a bandage on top of it, or you can as well use modern wound treatments. And if you remove the sponge afterwards from a chronic wound, use warm saline solution for a gentle removal. And the sponges, of course, can be cut to size. Can you see now slide number 7?
Yes.
Oh, very good. So there are a couple of publications available, and later on I can send you the publications. We do not have the time to go through all the publications in vascular surgery, but just to let you know that there is clinical evidence on that. Just as an example, I will show you a case report from a elderly male patient after a femoropopliteal P1 bypass, and then later on as well open wound healing, where you place the collagen sponge to reduce the bacterial load of the wound and also to aid wound healing. On the next slide, you see that after the extensive debridement of the wound, then they applied Gentacol periodically and changed the dressing after 2 to 3 days. And they always removed it with a little bit warm saline solution. There are a couple of indications thinkable for vascular surgery. But of course, treatment of infected wounds or treatment of chronic wounds is one of them, but also the prophylactic use in standard vascular procedures and as well in standard diabetic foot procedures. Is it moving?
No.
I think we have real technical problems here, but I think we spoke about that already. And if you have questions, I'm open for that.
I have a question, please.
Yes.
In the particular case you have showed about the infected bypass, did you use it as an implant and close the wound over it?
No, in that case of this case report, it was a secondary wound healing because it was completely infected.
And you used vac therapy?
Yes.
Okay, thank you.
VAC on top, but you can use it as well in open cases or in closed wound cases because it's an surgical implant. You can place it around your vascular graft, for example, and then it is fully absorbable within 7 days. So you don't have to remove it again.
Okay.
Our main problem usually in diabetic foot is the infection of the ankle.
Yeah.
When patient presented to us with ankle infection penetrating to the bone with exposed ankle, usually we need like antibiotic to be put inside. It with Gentacol it will be crushed if we put it inside a fractured ankle or opened gap ankle. We saw many cases with that, and sometimes the orthopedic surgeon come to fix it outside, external fixation, and leave to us gap to put the antibiotic over it. You advise to put it over bone, the infected bone, the first point, and to change with every time changing dressing. Because when I used it after 2-3 days, I didn't find it. It completely absorbed. Is it
Yes.
because the collagen?
It turns to gel, and therefore, if you use it topically, you think it's completely gone, but you will find, if you have an histologic view, you will find the collagen left over still after a couple of days. But yes, in some cases, it is quicker absorbed than in 7 days.
Yes. So I need to change it every how many days?
It depends on the moisture of the wound. I would suggest between day 3 and day 5.
Okay. Did I need cultures before?
It is always helpful to
Because many
know.
cases especially in Egypt, MRSA and Pseudomonas.
Yeah. So as the gentamicin is a broad spectrum antibiotic against gram-negative and gram-positive aerobic bacteria, I would say a culture is always helpful because then you know what you find or what you have in the wound, where you have to fight against. But usually the MRSA is not the biggest issue because you achieve so incredible high gentamicin concentrations that it is also effective against methicillin-resistant Staphylococcus.
Okay. Okay. Thank you.
Thank you. And if you have more questions, please let me know.
Okay. Is there any questions? Okay. Okay. Thank you. I hope to
Thank
see
you.
you in Egypt. We have a sunny day.
Thank you very much and have a nice evening.
Okay. The screen is obvious. The screen
Yes,
is
you can
okay.
see it.
Yeah, okay. Now, Dr.Shahd, as a branding manager for Elegant Care Medical Group, it will give us a 10 minutes presentation for Pharmactive product. Okay. Dr.Shahd?
مساء الخير. Hello, good evening.
Yeah, good.
تمام. مساء الخير. This is Shahd from Elegant Care. I'm the branding manager at Elegant Care for Pharmactive's portfolio. First of all, I'd like to thank Dr. Mohamed and the team for this initiative. It's a really good initiative to be a part of. And right now, I will be sharing my screen. Okay, just let me know that the screen is shown for you. Okay, is the screen clear?
Okay.
Yes, it's clear. Go ahead.
Thank you. Okay, so we're going to talk about Pharmactive's portfolio. We actually have a family of 3 products. Pharmactive Silver Spray, which is the oldest product we started with about 12 years ago. And our advanced dressings, Pharmactive Foam Dressing and Pharmactive Alginate Dressing. So our products are Italian products. They're imported from Italy, from Pharmac-Zabban. And Elegant Care, we are the exclusive distributor in the Middle East, and we handle several other lines, but our main business is with Pharmactive when it comes to vascular surgery. Okay, so this is our persona, this is our company. So Pharmactive's full portfolio. We will be starting with the spray and then moving on to the dressing. You'll find me presenting actually from my tablet right now because I find it easier to zoom in and zoom out in case we want to zoom in into any point and discuss it. So again, it's an Italian product from a company called Pharmac-Zabban. So Pharmactive Silver Spray is made of 3 ingredients. It's a triple action wound care spray from nano silver, first of all, 2% nano silver, which is the highest concentration in the Egyptian market, hyaluronic acid for wound healing, light kaolin and silicon dioxide to absorb exudates. So actually 3 different ingredients with 3 separate actions. So we'll be starting with the nano silver. So obviously silver is in lots of guidelines when it comes to the management of chronic wounds. And for our purposes, our product has nano silver. So first of all, let's speak about nanotechnology. So Pharmactive Silver Spray contains nanosilver molecules with the size of 10 to 15 nanometers. So it's nano. What is the benefit here? Being nano actually allows our silver molecules to act on the bacteria cellularly and subcellularly. So silver, generally speaking, it's an antimicrobial. It acts on a broad spectrum on bacteria and fungi. By having the positive ion of the silver, attached to the negative structures of the bacteria or of the fungi. When it becomes nano, as in the nanometer size, 1/1,000,000th of a meter, this actually allows it to have several modes of action. And it actually can enter inside the bacterial cell. So obviously bacteria is a microorganism, meaning that its size is in the micrometer range. So our product is in the nanometer stage. This actually means that we are 1,000 times smaller than the bacterial or the microbial cell. And this allows for very high penetration. So actually, all of these slides are screenshots from studies and publications available about nanosilver and Pharmactive. So again, if anyone needs us to share them, no problem at all. It's a pleasure to share a library about silver products. So actually here we have proven that Pharmactive and nanosilver as a molecule can act in at least 5 different mechanisms with microbes. So it can act on cell wall disruption, where the silver nanoparticles attach to the cell wall, as well as intracellularly with the ribosome, which ruins the protein synthesis process, mitochondria, obviously. So again, it breaks down the mitochondria. And by injuring the mitochondria, we actually get the release of free radicals. So again, this is another different mechanism in order to kill the bacteria or the microbe itself. And even intercalation between the DNA. Between the DNA bases, we can get the silver positive ion to attach to it. And again, this is a way or a mechanism for the attack of the microbe. So again, when we get this benefit, actually, when we have a molecule that can act with up to 5 mechanisms on the bacteria, this means that it has very, very low resistance. So we don't have to worry about resistance with silver at all. And being nanosilver, we need to worry less and less, being an antimicrobial. And as mentioned, since we have many cases in hospital settings and such of MRSA and VRE and Pseudomonas infections, nanosilver is actually proven to work against these kinds of bacteria, including MRSA and Pseudomonas aeruginosa. Next, we have biofilm inhibition. So actually, we do have a study showing that with the use of nanosilver, we got a prevention and inhibition of the biofilm formation, which again is a big difference in the wound, since it's very easy for acute wounds to turn into chronic wounds because of biofilms. So again, it has an action in the prevention of the biofilm formation. So this was about nanosilver. This is the star ingredient. Next, we have hyaluronic acid for wound healing. So we have an ingredient that has an action for the, let's say, infection phase and for the infection problem. And we have an ingredient that acts on the healing and helps with the formation of the granulation tissue. That's why with Pharmactive spray, we can use it in the infection phase and in the proliferation or healing stage. So it gives us a wide range of use since it has a combination of these 2 ingredients. Last but not least, light kaolin and silicon dioxide helps us with keeping the moisture balance. Since most of our chronic wounds are usually wet or are usually high in exudates, we have light kaolin and silicon dioxide as an ingredient that absorbs these exudates. So it also helps with the moisture balance. And something that we usually like to mention at this point also is that Pharmactive spray can be used with VAC as well. VAC therapy or negative pressure wound therapy, again, very moist wounds, and there's a need for an antimicrobial agent as strong as silver, so it can be used along with it at the same time. Same idea for debriding agents. If we're going to use, for example, whether surgical debridement or enzymatic debridement or whatever, it also can be used with Pharmactive spray. So moving on to our dressings. So this was the Pharmactive silver spray. So our dressings, we have 2 kinds of dressings, alginate and foam. So to understand, advanced dressings are available in order to provide proper moisture balance in the wound without harming the wound. Because traditional dressings, cotton, gauze, and such, they absorb exudates, but they do not lock them in. They actually might cause maceration in the wound. The wound becomes more damaged and does not achieve the proper moisture balance. That's why we introduced into the market, or we have added to our portfolio, Pharmactive alginate and Pharmactive foam. For the purposes of vascular surgery, with superficial and highly exuding wounds, we prefer our foam dressing, which I'll go through in detail. So this is the shape of our foam dressing. our foam dressing can last from 4 to 7 days, but it depends on the amount of exudates. But this is the average. So it's used on the wound as a dressing. It absorbs exudates and it locks them in without losing these exudates again, or having them making the wound more wet. It actually locks the exudates and exchanges it with oxygen. So actually we have this foam surface that has a semi-permeable membrane which can allow oxygen to come into the wound and exudate vapor to exit the wound. But again, we know that it's time to remove this foam dressing when it changes color a bit, and when it becomes a little bit thicker, when you can see that it's full, or it's becoming it has risen up. بنقول إن هي قبت شوية لفوق كده. It's time for the dressing to be changed. So again, we can use these physical signs or with the average of 4 to 7 days, depending on the wound. And of course, if the case is very, very heavily exudating, this case is going to need vac therapy and not dressing. So again, depending on the situation. So again, this is the shape of pharmactive foam inside the wound. It absorbs the exudates. It allows for the oxygen to enter the wound, and it also offers some offloading. As it's a thick layer of foam, it sometimes can be used to help with the offloading or with wounds that need offloading. And as I said, it's for superficial wounds because it's straight. It cannot be packed into the wound. The opposite goes for our alginate dressing. Our alginate dressing can be packed into the wound. Alginate dressing is actually more common with, I would say, deeper wounds that have cavities. So less with vascular surgery, but it's available also with some cases if we have cavities or such. This alginate is packed into the wound. Alginate, we prefer it for moderate to heavy exudates, but we prefer it for the moderate exudates sometimes. And the point with alginate is that it turns into a gel, actually. It causes a ion exchange. It's calcium-sodium alginate. An ion exchange happens, and what we get is a gel formation. And through osmosis, this gel absorbs the exudates. So it keeps the wound moist while absorbing extra exudates. And alginate is to last in the wound 3 to 5 days maximum, and again, depending on the wound exudates. And one of the really good points also with alginate, being calcium-sodium alginate, as we said, an ion exchange happens. So the calcium actually aids with blood clotting. So it actually helps with local hemostasis. So if we have a locally bleeding wound, we can sometimes use alginate to help with local hemostasis. So again, this is the shape of alginate, and this is how it looks. And we have a wide portfolio of sizes as well. For example, 10 by 10, 15 by 15, that can be used on our wounds. Okay, so of course, for the purposes of this presentation, we're mainly talking about vascular surgery indications. So we're talking about diabetic foot and venous ulcer wounds. So I'm going to skip this part. So again, how to use them together. So there's the use of the spray for the sake of the infection and the wound healing and moisture balance. And of course, the use of dressing for the sake of moisture balance and to prevent from the problems of the usual or the traditional dressing. And of course, providing the moisture balance and moist environment for wound healing. I'm just going to show you 2 quick cases with the use of pharmactive silver spray and foam. So this is the first case, diabetic foot. This was in November, 16th of November. We started using pharmactive foam and pharmactive spray. So you can see the formation of the granulation tissue starts until we reach this epithelialized form. The wound is almost closed. This is its latest progress. And this was in Feb. So we're talking about a 2 to 3 month progress. We went from this case, and of course it undergone debridement until we reach this epithelialized or almost completely epithelialized form. The other cases with alginate, pharmactive spray and alginate. So this was an abscess actually that had formed because of traditional dressing. So بالفتيل, sometimes if it's misused or packed too severely, you get an abscess. So in this case, this was in 20th of Jan. We used pharmactive alginate packed with the spray, and it started decreasing in size until we reach this stage in 1 month from Jan to Feb. So this was our presentation and this was our portfolio. And let me know if you have any questions or if I can help you with anything. And thank you for letting us host this presentation and be a part of this initiative.
Thank you, Dr. Shahd.
Most welcome.
Yeah, it was a very nice presentation. It can be used with children.
Starting from 6 months, it's okay. So sometimes Pharmactive spray, we started from 6 months. However, alginate, it can be used sometimes for circumcision, after circumcision. It can be used and it's very safe as alginate, not the spray. Spray starting
Yeah. For how long spray can be used? I saw case for 3 months.
Pharmactive spray can be used up to 5 to 6 months. Anything longer than this, we might get argyria. So it's safe, but you might get the discoloration of the skin or discoloration of the tissues. But usually by 5 to 6 months, the case is already improved and we can stop the product.
Okay. Okay. Thank you.
Most welcome. Thank you, Dr. Mohamed.
Thank you. Okay. This is all our presentation today. I will just put a news. I would like to thank Dr. Ihab Nabil. He's the Dean of Diabetic Institute. They are launching the Diabetic Food Diploma, sponsored by Monolith Company, the big company. They sponsored the Diabetic Institute for Diabetic Food Diploma. ده تطور رائع جدا 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 ومجهود رائع جدا من الاستاذ الدكتور ايهاب نبيل انه بقى عندنا في مصر دايابيتك فود دبلومه سبونسرد واز كفرد باساتذتنا من قصر العيني وبيستشارين المعهد والهيئه التعليميه، وده خبر جيد جدا وهنتابعه ان شاء الله. المحاضرة اللي جاية إن شاء الله دكتور عمرو عبد موجود، ده الكونسلتنت وهيد اوف فاسكولار سيرجري في الساحل تيتشنج هوسبيتال، وواحد من أعمدة المركز برضو مع الدكتور محمد رمضان ومعانا، وهيز فاسكولار دايابيتك فود سيرجن اند اند فاسكولار افتر 2 ويكس. هتبقى في نفس الموعد برضو هنتكلم على الكريتيكال ثريتنينج ليمب كونديشن، برضو ايه الفيو بتاعتها في الريفاسكولايزيشن. ليه الموضوع ده بيهمنا جدا؟ العيان ما بيجيش عندنا غير فيري ليت، يعني ما بنشوفش عيان كروديكانت قليل قوي، بنشوف العيان وجنجرين وزيشو لوس، وبرضه دكتور عمرو هيتعرض ليها بصوره اوسع بكتير برضه، وهنكرر المحاضرات دي تاني يعني ان شاء الله، وده بعد اسبوعين. ويعني اللي حاضر المحاضره يبقى دايما بس لينكد معانا في التسجيل عشان بنبعت اوتوماتيكالي المحاضرة اللي جاية، وكل محاضرة بنقول اللي بعديها بأسبوعين إيه اللي فيها في المحاضرات، ودي المحاضرة القادمة إن شاء الله. إن شاء الله في ورك شوب هاندز أون بعد أسبوع يوم الخميس اللي جاي الساعة 9 الصبح. وده رقم التليفون اللي عايز حد تريجستر معاه بيه. ده فري، مش مطلوب أي حاجة. ده هيبقى الموضوعات اللي فيه ادفانسد ووند دريسنج، وهيبقى ريبريزنتد باي فارماكتيف وجينتا كول. هيبقى في فرصه ان نقدر نتكلم بقى بطريقه اوسع واحنا قاعدين والحاجات موجوده في ايدينا. النيجاتيف بريشر ووند ثيرابي او الفاك ثيرابي، هاو تو يوز ات، ازاي تو ابلاي على جرح، وازاي تو ابلاي ان كومباينيشن مع كاست مع ووكر. الموضوع الثالث هيبقى الالسر اوف لودنج، وده هيبقى فول داي من 9 الصبح لغايه الساعه 3. اللي عايز معلومات اكتر هيبعت لرقم التليفون دوت، هيتقال له ريجستريشن، وهتبقى موجوده في الدقي يوم الخميس القادم الساعه 9 الصبح ريجستريشن. اللي عايز معلومات رقم التليفون ده ابعت عليه، وهننظم ديت ونقول الورك شوب اللي بعديها امتى ان شاء الله. دي خطوه بدينا فيها، ان احنا يبقى احنا على تواصل مع الاطباء، وفي التواصل دوت يعني احنا يعني از دايابيتك فود سيرجن اللي عنده حاله ومش عارف يتصرف فيها ازاي، خد راينا. مش مطلوب حاجه اكتر من ان احنا نقول لك خبرتنا، خده ليك يعني ان شاء الله. أشكركم جميعا، أشكر الدكتور محمد رمضان، أشكر جنتاكول وفارماكتيف إن هم موجودين معانا. رقم تليفون معايا، اللي عنده حالة وعايز يتواصل معايا يبعت لي تفاصيلها، أنا برد على الواتس، يعني هو مش تليفون لكن أقدر أتواصل مع مرضى أو مع الزملاء فيها. اليوتيوب شانل عليها المحاضرات دي كلها فري. المحاضرة بتاعت النهاردة هتبقى موجودة على اليوتيوب شانل من خلال يوم أو يومين. المحاضرات اللي فاتوا أعتقد دي المحاضرة السادسة، هيبقوا موجودين برضو كلهم على يوتيوب شانل مع بعض الموضوعات الأخرى يعني. أشكركم جدا، وأنا سعيد إن أنا كنت على لقاء بكم النهاردة، وأتمنى إن أنا أشوفكم وأقابلكم تاني إن شاء الله في المحاضرة اللي جاية إن شاء الله. أشكركم ونشوفكم على خير دايما إن شاء الله. شكرا لكم. وأحب إن أنا أشكر الزملاء اللي حاضرين معانا من السودان. أنا شايف أسمائهم، واللي حاضرين معانا من ليبيا هم على تواصل معانا، تواصل جيد جدا يعني، من السودان وليبيا. أشكرهم لأن أنا شايفهم معايا في الأسماء الموجودة يعني. شكرا لكم، ونشوفكم دايما على خير يا رب. شكرا.